pleasure and an honor to give you the first talk and give you a medical oncology perspective on precision medicine for lung cancer. The outcomes with lung cancer treatment at the beginning of the century were as depressing as this black and white figure from the seminal paper from Joanne Schiller published in New England Journal of Medicine in 2002. And what this study demonstrated is no matter what treatment we chose, no matter what platinum-based doublet we were using at that time, which was the standard, gold standard for treatment at that time, the outcomes were just as terrible, with a median overall survival here less than 11 months and less than 5% of the patients alive at 4 years. Fortunately, things have changed, and things have changed through two major breakthroughs in the lung cancer treatment. First one is a specific drug targeting of driver mutation that has dramatically changed patient outcomes and therapeutic approach. And the second is the immune checkpoint blockade, which launched the era of the cancer immunotherapy. The roadmap for treatment of lung cancer today is to do the NGS sequencing and to target the driver mutation if we find one, and if we don't, if no driver mutation is found, to do a combination of immuno or chemotherapy. How did we get there? Well, first of all, we had to understand that histology is important for lung cancer. And we knew for many, many years that lung cancer is not just one disease. We knew that is adenocarcinoma, squamous carcinoma, but for many years it didn't matter because treatments were the same and outcomes were the same and very poor for both. However, with time and with more treatments, we understood that squamous cell carcinoma should not be treated with antimetabolites and anti-angiogenic agents. So clearly, histology is a predictive marker. And we started classifying lung cancer by histology. We're talking about adenocarcinoma, squamous, large cell, et cetera, et cetera. And then the available biomarkers have advanced with technology, from the simple hematoxylinosin stain to more sophisticated immunohistochemistry. And now we are in the era of gene arrays. We can molecularly profile each tumor. We can exactly identify which genes are overexpressed or downregulated. So that had a major impact on the way we are treating cancer today. But the revolution really starts with the identification of the first driver mutation, EGFR, for lung adenocarcinoma, almost simultaneous publication in these two major journals, New England and Science, which showed that patients treated with EGFR inhibitors have a much better outcome than patients treated with any other therapies. And from that moment on, we started to subclassify lung cancer based on the driver mutation. And we identified some point mutations such as EGFR, KRAS, BRAF, MEK, PI3 kinase, and HER2. And we also have chromosomal rearrangements such as the ALK, ROS, and RET fusions. What I would like to point out is that at that time, and this is a paper published in 2011, almost half of the lung cancer have known driver mutation. And even some of the driver mutation that we knew, for example, KRAS, there was no treatment available at that time. Nevertheless, that made a big impact on the way we were treating cancer patients. As demonstrated here, the progression-free survival curves for lung cancer treated with targeted therapies versus chemotherapies are much superior. You have on the left panel erlotinib, which is a tyrosine kinase inhibitor of EGFR. And on the right panel, you have crizotinib, which is a tyrosine kinase inhibitor of ALK. Both drugs outperform by far chemotherapy in patients treated in that manner. Where are we today? We continued to refine our understanding of the driver mutation in lung cancer. And we have now identified a lot of new targets, such as FGFR, KRAS, PI3 kinase, and others. And I would like to point out that this piece of the pie, which is the unknown driver mutation, has shrunk to almost 12%. In addition to that, we further subclassified and refined the understanding of the known driver mutations, such as EGFR. We are not talking about EGFR mutations anymore. We are talking about T790M mutation. We are talking about exon 20 mutations. For BRAF, we are talking about V600E or non-V600E. So clear refinement of the understanding of the molecular drivers of lung cancer. And does that make an impact or not? Of course it does, because once we refined this understanding, we were able to come with second-generation tyrosine kinase inhibitor, which have better outcome compared to the first generation. So this study, which was just published and just presented at ESMO, shows that overall survival with osimertinib, which is a second-generation tyrosine kinase inhibitor of EGFR, It's way superior to erlotinib and gefitinib, as you can see on these survival curves. And what I would like to show you is that the median survival here is way beyond 3 years. And almost 40% of the patients are alive at 4 years and beyond, which is quite remarkable if you think of the first slide that I showed you. The same thing is true for ALK inhibitors. This is the ALEC study of alectinib, which is also superior to the first generation crizotinib in these patients. And again, the vast majority of the patients, 60% of the patients, still progression-free at 3 years. What about these new emerging targets? Let's talk a little bit about RET. RET fusions have identified in about 2% of lung cancers, generally young patients with adenocarcinoma, never smokers, and it's mutually exclusive with EGFR, KRAS, and ALK. And RET can be activated by 2 major mechanisms. Point mutations, which are mainly seen in medullary thyroid cancer, either sporadic or hereditary, or RET fusions, which are seen in papillary thyroid cancer, but also in other cancers such as lung cancer, pancreatic cancer, ovarian, colorectal, and others. And regardless of the mechanism of activation, whether it's point mutation or translocation or fusions, what's happening is that the genetic alteration leads to spontaneous dimerization of the receptor, activation of the intracellular tyrosine kinase domain, and oncogenic signaling. And of course, when you have a good target, we come up with good drugs. And I'm going to talk about 2 good drugs that inhibit RET, BLU-667 and LOXO-292. First, BLU-667 data just presented by Justin Gaynor at this year's ASCO. BLU-667 is a potent and selective inhibitor of RET alterations. Here you have a schematic representation of the kinome, all the tyrosine kinases families known to us. And as you can see here, BLU-667 is highly selective inhibitor of RET with very minimal activity, the smaller dots on other tyrosine kinases such as VEGFR and JAK1. And this is the proof of efficacy in xenograft models, which are RET-driven. Here, it's compared with cabozantinib, which is also a RET inhibitor, but more promiscuous. In this model, cabozantinib in red is outperformed by BLU-667, and BLU-667 results in almost complete growth arrest in these xenograft models. Here you have another model which is completely resistant to cabozantinib. As you can see, cabozantinib doesn't do any better than the vehicle, and yet BLU-667 results in dramatic tumor growth control, and that at IC50s, which are in the low nanomolar range, so very active drug. In the study presented at ASCO, 120 patients with lung cancer were treated with BLU-667 at 400 milligrams and above. The treatment-related toxicities were generally mild and reversible. This right column shows the grade 3 or higher toxicities, and as you can see, they were single digits with the exception of neutropenia, which is about 30%, and hypertension, 10%, which are quite manageable. Only 7% of the patients had to discontinue the treatment due to toxicities, including pneumonitis, colitis, some myelosuppression, and some gait disturbances, but overall very well tolerated. The drug has demonstrated substantial antitumor activity in these patients with RET fusions. So this is a waterfall plot. Everything below 0 means tumor shrinkage. And as you can see, the vast majority of the patients had tumor shrinkage, with about 60% of the patients achieving a partial response. And that was regardless of their prior treatments. In light blue, you have the platinum naive, dark blue, the platinum prior treated patients, same outcomes. The responses were durable, as demonstrated by the swimmer plot, which shows the duration on treatment. And as you can see, the vast majority of the patients were on treatment for more than 6 months, with many of them over 1 year. Most responses occurred early. These dots show when the responses were seen, most of them at the first CAT scan at 2 months. And 82% of the responding patients remain on treatment at the data cutoff. Median duration of response was not reached in this study, and some patients were on treatment for more than 24 months. The activity was seen across all RET fusion genotypes, regardless of the fusion partner, and also seen in patients with brain metastasis, as demonstrated by this spider plot. 7 of the 9 patients had tumor shrinkage, as demonstrated here, and no patients treated at 400 milligrams or above had disease progression due to CNS metastasis, which was a problem with other tyrosine kinase inhibitors in the past. BLU-667 has activity in other RET fusion malignancies as well, such as pancreatic cancer, cholangiocarcinoma, and papillary thyroid cancer. And the safety profile was similar with that reported in the lung cancer patients. Let's talk about the other drug, LOXO-292. Data were reported last year ASCO and updated at the lung conference this year. So LOXO-292 is also a potent and selective RET inhibitor. Again, the kinome, you can see that LOXO-292 only inhibits the RET family of kinases with very little or no activity on the other kinases. And these are 7 xenograft models RET-driven. Cabozantinib has very marginal activity, while LOXO-292 has impressive activity in all these tumor xenografts. In the clinical study, responses were seen across all types of cancers: lung cancer in blue, thyroid cancer in red, pancreatic cancer in yellow. And regardless of the RET fusion partner, very similar with the blue drug. And these are the updated data from the World Lung Symposium. And as you can see, again, the vast majority of the patients' tumor shrinkage with partial response achieved in about 68% of the patients. And that was regardless of prior therapies. As you can see, almost all patients had prior chemotherapy. Some patients had immunotherapy, and some of them also tyrosine kinase inhibitors prior to enrolling in the study. In conclusion, LOXO-292 demonstrated robust antitumor activity across all RET-altered cancers. The activity was independent of the fusion partner, the mutation, or prior therapy. And the safety and the tolerability were consistent with a highly selective tyrosine kinase inhibitor with no evidence of any off-target toxicities, and maximum tolerated dose not reached. So remember the roadmap for lung cancer treatment. This has evolved, and the new roadmap says that after we do the NGS sequencing and we identify driver mutations, at disease progression, we have to try to rebiopsy to identify the mechanism of resistance and retarget with a mutation-specific drug. And only if no driver mutation, then we use immuno or chemotherapy combinations. So what about the elephant in the room, immunotherapy? Well, immunotherapy does well in lung cancer. As you all know, and as presented in this seminal paper in New England Journal of Medicine, the addition of pembrolizumab to standard doublet, Alain Mita and platinum, resulted in significantly longer survival and progression-free survival compared to chemotherapy alone. And these are the survival curves. Clearly, the triplet, pembrolizumab and chemo doublet, does much better than chemotherapy alone. And again, I will point out that nearly 70% of the patients are alive at 2 years, which again, keep in mind how the first slide looked. Now, my only comment is that there is no biomarker for patient selection in this study, and this for a drug that costs over $200,000 a year. And I don't want to be negative, but if you look at the progression-free survival curves, you can see that almost half of the patients have disease progression at 6 months here. So that means that they don't really benefit from this chemoimmunotherapy combination, and they would be better served by other treatments, other drugs that we have to still discover. So at this moment, we still have this dichotomy, this antagonist targeted therapies versus immunotherapy. And this is driven in part by the fact that the decision to give immunotherapy and chemotherapy should not be made without first knowing if the tumor has an oncogenic driver mutation. And that is for several reasons. Number one is that these tumors that have a driver mutation generally don't respond very well to immunotherapy. So there's a potential lack of efficacy of immunotherapy in these patients. Then there is a potential for increased toxicity when you use TKIs after immunotherapy. There are some studies published recently showing that the rate of pneumonitis when you use TKIs after immunotherapy can be as high as 50%. Additionally, the response to TKI may be a little bit shorter, and the patients may have more resistance mechanisms after being experienced and exposed to chemotherapy. But imagine how nice would it be, and instead of having targeted therapy versus immunotherapy, we would have targeted therapy and targeted immunotherapy in selected patients. In other words, if immunotherapy would proudly announce the engagement with precision oncology, wouldn't that be a marriage made in heaven? So my last slide is about unmet needs and my wish list. And as a medical oncologist, my wish list includes a reduced turnaround time, which is a critical aspect of the treatment decision process. I would like to have a reduction in the number of inconclusive testing and to avoid rebiopsies, which are very difficult in these patients. and also to build on the value of the interaction with the pathologist via molecular tumor boards and other means. I have the pleasure and the privilege to work with Dr. Vail, who not only participates in all our molecular tumor boards, but is also very available, phone, email, text, and helps me make these sometimes very difficult decisions. And I hope all of you will have the same privilege. Now, last thoughts about clinical trials. As you all know, nothing can be done and no progress can be made without clinical trials. And the NCCN guidelines state that the best care for cancer patients is within a clinical trial. Yet only 5% of the cancer patients in this country are enrolled in clinical trials. Keep in mind that without clinical trials, we continue to practice yesterday medicine instead of the medicine of the future, and that the first cure of patients with advanced cancer were seen in phase 1 clinical studies. And therefore, to me, every clinical trial is a new hope for cancer patients or a new dawn, and as this favorite painting of mine from Monet. And with that, I am done, and I thank you for your attention, and I'm happy to take any questions you may have.